Thanks very much, Jimmy. I am proud to say that you were my mentee. I'll later go on and point out that my mentees are now all my mentors, and some are my bosses, which is really great. And if Dr. Schwartz is around, and there she is, those two are now taking good care of me, and so I'm in good hands. I am very nervous. I always get nervous before speaking engagements. I think that's okay and healthy, but I am, two warnings. One is that when I went through the slides this morning, I was a little worried. When I did my first grand rounds in 1977, I had a whole talk prepared, and I got through it in 6 minutes. And Dr. McHugh went, oh my. He had a lot to fill. We had 90-minute rounds, as you pointed out then. So we had a long discussion. And so I'm going to speak slowly, which is not my norm, and see if we can make some sense of this. The other warning is that I love teaching, and I love seeing patients in a teaching setting. And so I know there's some residents here today, and this talk is oriented mostly to residents. So I apologize to the experienced clinicians who know all this and probably can correct several things I say that are wrong, like Russ Margolis up there. But we'll see how it goes. I am going to show some data at the end because we're talking about prognosis, and I'm going to present a patient today and talk about how the Meyerian history and the perspectives should drive a long-range treatment plan, okay? And so when you're doing that history, laboriously writing it up at night, wondering, gee, does all this really matter? If you take care of the patient, it certainly will, okay? So, so prognosis, a fundamental task but increasingly neglected, how to do it and use it in treatment, okay? Let's see if I can, hit the wrong button, thank goodness, I hit delete. I hope that didn't happen. So the objectives today are, and again, this may be like a CME quiz for the residents, contrast the priority of diagnosis and prognosis in the Hippocratic versus the Oeslerian era. And in case, I'll flesh those words out later. Describe 3 reasons that prognosis is so neglected in medicine today. It is in all of medicine, not just us. And what's lost in treating psychiatric illness if you do neglect it. And then finally, describe how the Meyerian examination and the 4 perspectives inform prognosis and should guide treatment plans. I've always taught in different clinical settings, and actually some really important ones when people were debating and arguing up at the Cold Spring Harbor. This is where this slide came up. I said, look, patients really come to us in consultation with 4 questions, and I put them in the sequence that makes sense to me, and they don't always come up in that sequence, but these are the questions that patients have. What is wrong? Patients want to know what's gone wrong, not just a name, right? How did it happen, which we often do not know. I think patients have a sense that if they took 2 steps backward, they might be able to walk back out of it, or at least if they can't, they can tell their children, right? Don't walk into this, right, if there's something that I might be doing. The next very important question is what will become of me, okay, which is prognosis, right? And you have to have that because otherwise you don't know how to interpret the next step. What should we do about it, okay? So this is going to be resaid by smarter people than me in a few slides to come, but this is the way I experienced it after my first about 3,000 consultations. Said, yeah, these are the questions I'm getting. Okay, I thought I was going to be talking mostly from an ancient paper from 1997, but it turns out I went down a rabbit hole reading papers and a couple PhD theses where people were talking about this. And in 1913, Dr. Anatole Chauffard was invited to the 17th or something like that consortium or convocation for medical history in London. And the title of his talk in 1913 now was the year that the Phipps Clinic opened, by the way, was medical prognosis, its methods, its evolution, and its limitations. And I hope this is readable. I'm worried about things being read in the back, and if people halfway up can read it, can you read it? All right, look at that. Thank you. I sit way back, and there are a lot of slides I can't read, so. I'm sorry? Oh, yeah. Oh, I'm sorry. I'm a little off kilter here. I need a patient to present, right? Sorry, folks. I'll get right back to this. Cure, be affected. Can I be cured? And if so, by what means? Okay, and that interesting, going back to before the modern disease model took over as our zeitgeist, which we'll talk about. That was the question, and he said only later, in an entirely modern idea, is that of defining each particular case, the mutual relationship between those three fundamental elements: to know, to foresee, and to act. That is diagnosis, and that is what the word means: to have a thorough understanding of something, to foresee, the prognosis, and to act. Okay, and that's sort of the doctor's side of it. But as I said, there's the patient side of it too, because this is a collaboration from the get-go. Okay, I want to see if that shows up. So the paper, though, that got me really going on this was by an internist and sociologist, Nicholas Christakis, who had done very masterful work as a sociologist at the Framingham study in Massachusetts, where he was looking at social networks. And it turned out that people were, at the earlier days, the big issue was for people to lose weight and stop smoking, okay? And he showed that if you were in a network with people that were stopping smoking, you were more likely to stop smoking than if you weren't. And similarly, if you were in a network where people were losing weight, that also had a good contagion effect. And even if you weren't talking so much to the individuals about it. So that was it. And he's gone on since then to look at many, many other things that are influenced by networks. And I think some are newsworthy for us. Now, the thing he did say, though, was that the current textbooks, by the way, he picked a textbook to use for his study of prognosis here, and his name of this paper was called The Ellipsis of Prognosis. It was written, and that was his PhD thesis at Penn when he was getting his PhD. And he said that current textbooks, when he went through a bunch, but he used the Osler's Principle and Practice of Medicine, editions 1 through 8, as his guide. He was going to study prognosis and whether people focused on it in the textbooks. And he said current textbooks, beyond those, even infrequently consider prognosis explicitly, and even less frequently do they devote special sections to prognosis. Okay? And in fact, so here are the first, do I have a pointer? I don't know, maybe I don't. Luckily, I put red arrows in a few key places. The first one, down on the bottom on the year, is 1892, which was the year of the first edition of Osler's textbook. The one up at the top is over these ensuing years, from 1880 to 1977 or so. What happened with the discussions of diagnosis? Diagnosis is up there at the top, so it's now most of the stuff in a chapter. And down at the bottom, the lowest, the one that hits 0 there and starts at about the 10 or 12% range, that's prognosis. So it went from being an equal partner with diagnosis and treatment to disappearing, okay? And the assumption was, he said, this was because the whole nature of diagnosis and the notion of disease had changed, and that the idea of treatment and cure, because you would have a rational understanding of the whole thing, became the evident thing. And for some infectious diseases, that worked very well. And I loved pneumococcal pneumonia when I was a medical intern here, because I could diagnose it at the syndrome, the pathology, and etiology level in 6 hours, and I could come back in on the ward, with the slide, the gram stain that I did myself, and say, I can give penicillin and I'll be a hero, at least for a while, okay? And interestingly, when that first patient showed up 6 months later again, and I had him again for another pneumococcal pneumonia, I did ask my resident, what didn't we do? And he said, well, did you give him the lecture on drinking? And I said, no. Should I? And he said, well, you didn't do it, so do it, okay? So I later reviewed the literature, and occasionally that does help. So it all depends on whether the person's at a teachable moment space, and so sometimes it does. So I should have done it earlier, and I didn't, although I don't know that the speech is really what this fellow needed. So here is, so we're talking about Osler's textbook of medicine. It was one of the first, if not the first, that went disease by disease by disease. Now, Osler was a master clinician and certainly knew his patients and did a thorough history of them, okay? But he also was had been a pathologist as well as internist, and was very keen on putting the diseases forward in a rational way. And that's where this modern disease model, often referred to, especially around here, as Oslerian, the era of Oslerian medicine, came from, and where I learned this model from Dr. McHugh and Philip Slavny, okay? That is, we go from a clinical syndrome, where you and I will see the patient, back to validating it with a pathology, specific pathology, and then studying that. Now, once you have a pathology in your hand, you can say, how did this come to pass, right? That's etiology. And then there's these links between these pillars. These are the three pillars, but the links between the pillars, pathogenesis and pathophysiology, are wonderful places. And I say here, David Lewis adapted Dr. McHugh's drawing here and used to tell his students, when they came with an experiment they wanted to do, to put it on the map here. So here's a map of the disease. Tell me where it fits, okay? The rest of that is pretty clear. You all have seen that 100 times, but I wanted to make the point that we give Osler credit in a way for both. He didn't create the disease model, okay? As I say, there lots of other wonderful people did that, but he did at Hopkins change the education of physicians, students, medical students, to fit that model, and that's been the model really ever since, okay? So, when Dr. McHugh started teaching me, he said, well, this is one of 4 ways of looking at the patient, but it's not the only way, and it's not the only important way, right? So this model has done a lot of good. Survival on the planet has changed enormously, but some people would say we have a too narrow view of our patient too. So back to Chauffard, he said, so what then are the limitations of medical prognosis? And an essential distinction, he said, must be made here between theoretical and clinical prognosis. Theoretically, almost everything is known to us, thinking of the disease model. And that was 1913. I don't think that's quite true. In fact, it's still not true. But that was the feeling, that we would really know everything about it. And but all that is book prognosis, he says, far removed, unfortunately, from the living individual prognosis, which relates not to a disease, but to a patient. Okay? And that's really important. So listen, in terms of discussions, I was saying that the whole idea of diagnosis is a discussion, prognosis is certainly a discussion, treatment is a discussion. The National Academy of Medicine in 2015 put out a report from their series beginning with Error is Human and a few other things on making healthcare better and safer. One of the reports was on improving diagnosis in healthcare. Okay? And they defined prognosis, they defined a diagnosis in this way so they could come up with a diagnosis, with a definition of a diagnostic error. So they wanted to know, what's a diagnostic error? And so, since their definition of diagnosis was the development of an accurate and timely explanation of the patient's health problems, okay, and then they emphasized the processes of collaboration, and you have to communicate that to the patient, like Dr. Zinger. Thus, a diagnostic error is a failure to develop an accurate explanation, or the failure to communicate that explanation to the patient in a timely fashion. Okay, so. I like that. I think that fits. It goes with the meaning of these words, and that's how I'll judge it. So that's why then I've got to come to diagnosis in our field, which has been dominated by DSM, and with DSM, as many of you know, what became an operationalized classification scheme in 1980, and it came from a group at WashU who had gone around. John Feiner was his name, and he had adapted a short list of things that would be diagnosed by going around to clinical research groups and asking them how they diagnosed it. And what they handed him every time, it seemed, was their ascertainment criteria for their studies. Okay. Remember, those are the words and the wave structure that was used to create DSM-3. He only gave them 12. Okay. They added many more on the committee. But importantly, back then, 1980, to manage sectarian disputes in psychiatrists who all belong, what school do you belong to, kind of thing, the leaders stipulated that no causal inferences would be part of a DSM-3 diagnosis. And by the way, that's been reaffirmed over and over again in later editions. Problem with that is we're supposed to be explaining things, right? So what do we have to explain? And the answer is, thank goodness, a lot, okay? So let's talk about that, okay? So, so far it also mentioned the issue of a mutual relationship, obviously, between diagnosis, prognosis, and treatment. And the point is that any way you look at it, prognosis is an element of all diagnoses. After all, a diagnosis doesn't get in the books as a disorder unless it has a prognosis that's a worry, right? That's our job, okay? And secondly, at the most concrete level, I thought a nice thought experiment for medical students would be to say, who is first seen and last seen in an emergency department or an urgent care facility? Is it first come, first served? No, of course not. And those distinctions are made largely by prognosis and treatability. So if we have a patient with an MI, a potential MI, a patient with potential cancer, and a patient with Huntington's disease sitting side by side, you can figure out that it's going to be the patient with a possible MI that's going to be seen first, because not only does that have a very short-term prognosis that's important, but there's something we can do about it, and he can go to a special unit, namely the coronary care unit. Okay. And finally, all treatments and interventions are only justified by likely outcome of the health problem, right? If you have a strep throat and you go to the doctor and you ask, well, what's going to become of me? He'll say, well, in 2 weeks you're probably going to be fine, right? So whether you take the shot of penicillin or not, you're going to be fine for the most part, right? I would have taken the shot. I probably did a few times. So prognosis is inherent, and therefore we do have quite a lot to explain because there have been a lot of studies. The prognosis, I'm going to tell you, comes out of this. Now, this talk today is really a follow-up to a talk I gave in Grand Rounds previously and a little paper I wrote in 2017 called 100 Years of Hopkins Psychiatry. And again, I don't see a pointer. Is there one here? No. All right. So on the left, the top left, is a picture of Adolf Meyer as a fairly young man when he arrived here in Baltimore. And the manual behind him is a manual made up of what he distilled out should be the psychiatric history. Dr. McHugh wrote a wonderful paper on Meyer. That's in the same issue in 2017 in the Journal of Nervous and Mental Disease. And he was a pathologist and would do autopsies at a state hospital where people would come and live the rest of their life, and would find a brain that was very intriguing, maybe had an abnormality, and he would run for the chart and find nothing of his needs in it. They would have about how many meals the person ate, how many times the family visited, and was the patient still certifiably insane. Our job back then was very different than our job. Okay? So, but that manual was basically developed, though, when he went to the New York State Hospital Organization, now the New York State Psychiatric Institute. And his associate, George Kirby, put it together. And when he got tired of mimeographing it, he said, for doctors and people that wrote in, they then published it as a little pamphlet, which is available to us. And that little pamphlet is also summarized in the Meyer-Gross and Slater and Roth 1954 edition of Clinical Psychiatry, and actually 1959 as well, called The Examination of the Patient. Well, that's part of the story, and that's very important. But the other part of the story is that Dr. McHugh and his training was looking for a residency that he thought would teach him what he needed to know, and wasn't satisfied with what he saw in the U.S., and so he did a neurology residency with a lot of neuropathology in it. I think maybe in a way that's perfect training, right? Neuropathology, neurology, and then psychiatry, the queen of the training systems. All right? And they saw that what Meyer didn't give you, though, was a way to interpret his history, that detailed history and examination of the patient. And it was also true that and so they wrote the Perspectives of Psychiatry to try to say, how are we going to interpret all this, and how does it fit together? And you guys are going through all that now, okay? And this is the 1998 edition. Their first edition was only 125 pages long. I used it to teach the first-year course in psychiatry, and I found a wonderful outline, but that it didn't work as a textbook, okay? And so they got this now out to 300 pages, and I think they do a wonderful job of it. So, and you all have seen the perspectives, all four of them, the disease perspective, the dimensional perspective, behavior perspective, and the life story perspective. And so I won't go into this, but I do want, my little note here is that these are not definitions of words. These are operational models with structures and logic to use as a guide for reasoning about what lies ahead and what set of strategies to have near at hand for the patient, okay? So these should be your maps, okay? And your logics as well. Okay. Yes, sir. What am I doing? Aha, okay, there you go. Is it working? That's better? Okay, for the back, I apologize in the back row for doing that. That's important. The back row, I care a lot about it. That's where I sit, okay? And then here's your outline of your write-up that your residents do of the Myrian or Phipps case note, and it starts with family history and personal history and medical history and premorbid personality before you ever give the psychiatric history. This puts the history of the person before the history of the problem, okay? And that's essential and very important in prognosis, actually in other ways too. So, and in our patient today, he's already told us a lot about this. He's had various issues in his work history that have shaped his life and are a worry. He had a brother who was equally bright who couldn't hold a job for more than a few months. So, and it's also, I'll show a little data on that later. He also had childhood health problems, right? And he had some vision issues and some hearing issues from there that might have a relationship to some of the illnesses he has. There's a very strong family history we talked about of bipolar disorder, not just depression, but also very strong family history of suicide. So he actually does have a legal history, unfortunately, due to his bipolar disorder and a manic episode. And as I said, his premorbid personality, he sort of described as well. He said hard-headed. I said perfectionistic. He said perfectionistic in the office, but also extroverted. So he likes to talk, and he and I both enjoy it. So then we do now it's not that the psychiatric history doesn't matter for prognosis. Of course it does. And the disease has got to start where you start. And the disease severity and its chronicity are extremely important. Now, here's the point. The first lecture I got in this hall when I was a third-year medical student and just finished basic sciences, survived the Krebs cycle, as I like to call it, was given by Dr. Philip Tumblety, pictured here. And he gave us our first lecture that Dr. Scheffler was in, as well as me, our first lecture on the what is a clinician and what does he do, okay? And amongst the other things he said, that a clinician is one whose prime function is to manage a sick person with the purpose of alleviating the total effect of the illness, okay? That means think longitudinally, okay? Management of a sick person entails much more than diagnosis and prescribing of medicine, demands much more of the physician. As I say, in psychiatry, that's doubly true. And so I do want to show a little data on this. So Dr. Zinger is right. He's a step ahead of me. I haven't told him about these studies, but it is true that our patients, as you all know, with schizophrenia, bipolar disorder, and severe depression do die somewhere in the range of at least a decade earlier than their colleagues or their fellow travelers who don't have these illnesses. I think that is a reflection on the severity of the illness and how it does disrupt lives, okay? And people don't take care of themselves. And there may be other factors as well, but I think that's a big one. Nice study done here by Dan Ford was that he could explain all of the impairments in depression and on heart disease, the relationship between depression and heart disease, he said could be explained simply by the patient not taking care of themselves. We know that may not be the whole explanation, but those things can be measured. And now this relative risk column in the middle here, first on the left side, this is a meta-analysis of many global burden of disease studies and other studies. And so the number of studies is on the left. The relative risk of death at any given period of time is given in the middle there. So that compared to a person who doesn't have the illness, a comparator, a patient with psychosis or bipolar disorder has a 2 to 2.5 greater likelihood of dying in that period of time than his fellow traveler, okay? So, and that's kind of hard. That doesn't give you a picture of it very well, but that data did come up in a picture in another paper, and here it is. But this isn't, again, is the reverse of a hazard curve. This shows how many people are dying, what percentage of the cumulative group are getting what does it says? The cumulative incidence proportion, and the item is death, okay? And so you can see the patients with bipolar disorder are dying more frequently than their age and sex match reference individuals. The numbers at the bottom, by the way, since this study went in many patients over 50 years, are the number of patients still surviving at each time point, at each 5-year mark, okay? So you can see this population got smaller and smaller. And also, in another study with very similar data, Dr. Kessing showed this very interesting but difficult to read finding, and that is that he showed that he wanted to look at the number of life years lost and when in the life cycle of the person did they sort of lose them. That, to me, was a difficult concept, okay? But what he shows here is that in the general population, in their first 15 years, the expected survival after that assessment, in the first of the 5-year intervals assessments, was that the patient still had 60 years of expected lifespan if they were a normal, non-ill person, okay? And then down for each year up to 75 years, obviously they have less likelihood or less lower rates of losing years of life compared to their neighbors. And you can see that under bipolar disorder, the patients that were expecting 60 years of life, the other ones, the bipolar patient could expect 48 years of life, okay? Now, over here on the right, these two columns are, well, what's the difference? Well, it's about 12 years, as you can see on the first line. And 58% of that, the last column, is due to natural causes, not suicide, okay, or accidents. So the point is that the life years lost observed starting at younger ages suggested to Kessing and others that this represented support for what's called the accelerated aging hypothesis. Now, I've heard of the accelerated aging hypothesis. What does that actually mean? And his point is that if it's already starting, if your deficit in life expectancy is starting early, well, these other diseases that we usually die from have aging as a big part of them. So that he makes the point that this should theoretically at least open the door to say, get these people into treatment for their disorders, all of them, and you can make up the difference. And there's some evidence that that's the case, although that's, I think, where the research is going now in epidemiology, okay? So I hope that's reasonably clear. It took me a while to get it. And I mentioned work functioning, and here's a slide that shows the work functioning problems in a series of patients with bipolar disorder, given as to whether they had good or poor job functioning in the 3 months prior to an episode. And you can see that about a little over half of them, 42 of them, had poor functioning. And what they later showed is that poor functioning, in fact, was a better predictor of an upcoming episode of depression, particularly, but also mania, than just having symptoms were. Because most of the patients have some symptoms, some of the, a very large percentage of time, although not so severe. But if they're not functioning well at work, that's a strong predictor that they're about to go into an episode, okay? Yeah, thank you, okay. So, got two more slides, most. So the last data slide I want to show, the last data slide I'm going to show is really one that I like. It's an advertisement for our bipolar clinic over in the 550 building, started by Dr. Goez, and our side of our campus is run by Dr. Bond. And this shows, again, from Dr. Kessing, his proportion of patients who were readmitted over the 6-year period who were treated with bipolar disorder, either in a standard clinic or in their special mood disorders clinic. And this is that curve turned upside down so that the people that are in the mood disorders clinic don't fall ill as quickly as the people who are in the standard clinic. So Dr. Singer, welcome. We're going to do our best. So let me just make a point here before us, and that is I have too many people to thank to name them all, but thanks to all of you for being here. I love seeing patients, and this may be my last grand rounds, but not my last word. Besides the teachers of McHugh and Slavny, I've had the extraordinary chance to work with Dr. Kay Jamison since 1987, with Barbara Schweitzer, who is here somewhere, since 1990s, hiding in the back, as usual. And with Tim Moran, who I don't know how long I've known Tim, okay? And many others. But I'm delighted, as I mentioned earlier, that my mentees are now my mentors and my directors. And so thanks very much. I already ate up part of my question and answer time, and Jimmy nicely pointed out to me, Ray, let's go.
That was really interesting, Ray. Yeah, prognosis is a fascinating issue and one we don't talk about very much. Let me ask you about one prognosis issue that comes up fairly often. I'm sure you've dealt with it many, many times, and that is this issue of a young person with a relatively new onset mood illness that has psychotic elements to it, and you're trying to talk about diagnosis and prognosis there. Talk about how you handle that.
Well, I mean, I think first off, with young people, you've got to help them understand that this is this disease, and we do know something about it. As Chopard would say, it's textbook what we know about it. That is that this is a very relapsing and recurring illness, and we don't want it to relapse, and if it's going to do so, we want it to be at a great distance, not a short distance. And multiple episodes in a hurry are very disabling for people. So the question is, how do you persuade them? I think it depends on you and the person. And our patient really knows a lot about these things because he's been in the medical area, but most of the young patients I have not. And I certainly have found that with young men, I can remember early on, my first patients, it took sometimes several admissions before a patient, a young man who I remember very vividly, came up to me in the hall of East 3 over in the Phipps building and said, "What was that you were saying about lithium? Okay, maybe we should talk," right? But that was 3 admissions. And he had already had to change jobs, and eventually his jobs changed in a good way. So, and he got married and had children. So, but it took a while, and luckily he survived that. But many do not survive it, at least don't survive it intact. Yeah.
Thanks. Other folks have questions. Dr. Nestat. Thank you. That was the slide I didn't show. Okay, but I've reviewed, and Dr. Jamison keeps me very attuned to these papers that show that the data at least says that there's a strong association between getting on treatment with things like lithium and not dying as soon, not having as many of these other diseases like heart attacks and so forth. And so yes, that is, and also. Lithium apparently has a fairly significant, at least in bipolar disorder, anti-suicidal effect. So it's extremely important. That's the part, yes, that Dr. Zinger and I will talk about now that he's raised the subject. and I would say, when do you raise each subject? You don't raise them all at once. I'm not going to give them the whole lecture here and go through each of the disorders, but there's a whole list of 10 or 12 chronic illnesses that having bipolar disorder means you're going to get more of it, ranging from Alzheimer's to arthritis, to COPD, to heart attacks, as you know. So they all are in there, and most of the life years lost are due to those, not due to suicide. Okay? So, but thanks. Yes, treatment matters, and I saw some later studies But those studies are hard to do, and because you've got to say where the window is that you're looking at, and how long do you follow the patients? Do you really know, right?
Thank you. Other folks, Dr. Bienvenu.
It sure is, and thanks. That's a great question, and it's a question I've been asked to write about as well, and I think that's where real clinical experience matters. Okay, so the question is, well, what's the data for it? What's the data against it? And it used to be before DSM-3, when I was practicing psychiatrist, I would talk about that after a consultation, and that is, I'm not sure today whether you have clinical depression that should be treated medically or not. As my medical attendings, as well as good psychiatric attendings, taught me, you don't have to do all the tests in one time, and in psychiatry we can't. There are no tests to do often, okay, other than seeing the patient again. But that's the key test, he says, even in medicine, is if you think the patient is well enough and has enough social support, a very important part of the prognosis in general, have them come back in 2 weeks or 2 months, and that's what I used to do. Was have them come back in 2 weeks or 2 months, and not necessarily start them on treatment. For some patients, that it's the weight of the evidence is so strong and the outcome is so uncertain that the weight of the evidence might be start them on treatment anyway. Okay, so I don't know if that kind of gets to your question, but we've got a lot of experience on that, and that's what we have to do, and that's called clinical judgment, right?
Thank you. One last question, Dr. Rupel.
I was going to say, I think it's everything. Okay, that's the only reason you have a patient there who will come back for the next visit, right? Is there something good in this? There's something for me, not just in this. So I think it's extremely important, and that's what if you walked the halls with me, which you have done, you know that that's part of what we preach. And let's get on the team together and see what we can do. Okay. Kay Jamison's point, though, really important about therapy, when she, in her latest book about Fires in the Dark, is that when she met her psychiatrist, he said, it's going to be difficult, but we can do it. Okay? And she thinks we should emphasize that it is difficult. It's not an easy task, which I think is very fair. So thanks again, Kay, and thank you.
Thank you, Ray.